you guys so much for coming. This is still a precarious, kind of strange, fearsome time, and it just shows, I think, how much people really want to connect, and the importance of our conversations and ideas, that people have all come out and come here to join us. So I'm really grateful for that. Looking forward to it, and more people joining us online, and thank you for being patient with our technical setup. I think we're all headed into a universe where we have to learn how to use both Zoom and in person, and so once again, things are changing and made more complicated, but maybe there's some virtues. So I'm Amy Kapczynski. I teach here in the law school. And the first thing that I want to do is thank the people who really helped this all happen. So Corinne and Brianna. Is Brianna not here? We'll thank her later. And all the folks at the LPE Project and GHJP, and Sarah, who also bought everyone cookies, which you can take on your way out because we're not allowed to eat in this room, but she didn't want you to go home hungry. So take some cookies on your way out, and thank you, Sarah. Okay, so today we have a wonderful opportunity to talk about neoliberalism and healthcare. It's part of a series on the politics of care that we've been running through the LPE Project and GHJP, and encourage you to come to our one more event in the series. And part of the sort of, I guess, just to say a few minutes about sort of the convening of this panel and why we brought this group together. In some ways, this series began with our thinking about COVID, where I think from the earliest moment, it was clear that the kind of public health system, the community health system, the healthcare system that we had set us up for a kind of terrible devastation that we've seen since. So not only the kind of features of our healthcare system that leave many people entirely without insurance, and that kind of create profit-driven healthcare that has prioritized profits and high-tech care, where questions about how many beds we have are really run through a kind of profit maximizing kind of equation, but also the decrepit state of our public health infrastructure, where it's all been I think made painfully clear, but the systematic underfunding of public health, just since 1980, we've had a reduction of the state and local public health workforce from nearly 500,000 to under 200,000 jobs, right? So really systematic dismantling. And then, of course, we'll be talking today about health equity and all of the evidence is mounting, which some of you are writing about, right? About the ways that we are able now to produce data and arguments about health equity, which of course we saw very much present in the conversation also about COVID and who bore the greatest burdens of COVID. I guess part of the thinking, and some of us will be on the panel will be talking about some of the ways to connect all of these features, thinking about either markets or kind of the market-driven nature of healthcare, but also the term neoliberalism. Maybe I'll say a little bit about what that means, since it's a part of the framing of the panel and not everybody may be familiar with that idea. But broadly, looking out at you, most of you grew up with it. It is the air that you breathed, often described as the idea that free markets will be, work best and allocate and sort of orient our economy and also maybe even our politics if we just leave them alone and don't regulate. And so, in its height was sort of kind of there's a political period that's associated with the rise of neoliberalism, is sort of Reaganism and Thatcherism and the Washington Consensus globally, the idea that we should deregulate, sort of dismantle labor unions and labor power, and sort of make markets more pervasive. So you can think about the trends in healthcare to sort of put more costs on individuals so that they will engage in, appropriate use of healthcare and not overuse healthcare, things like that. Consistent with the way that neoliberal ideas kind of move through both law and policy circles. I think that the more sophisticated way to think about neoliberalism, the way we talk about it in law and political economy circles, is not actually just about deregulation, but about a kind of re-regulation. Some people are actually more regulated in this period. It's the same period of the rise of the carceral state, right? The militarization of our borders. And so really, I think we have to think about neoliberalism as a kind of a program to liberate certain kinds of market actors and empower them over democratic actors. And how that works out in healthcare is going to be one of the things we'll be thinking about today. And so we have this wonderful group of people to help us think about the politics of care and healthcare and sort of how to both diagnose, sort of think about forensically kind of where we are and where we also might go next, which is, I think, the most important kind of part of our conversation. So we're going to start out with Julia Lynch, who's a professor of political science at the University of Pennsylvania. She's a PhD from the University of California, Berkeley. And her research focuses on the politics of public health, social policy, and inequality in the rich democracies, and particularly Western Europe. And Julia is going to talk to us some about, I think some people in the United States would think if we could only get to Europe, like if we could only get to a sort of healthcare system and so forth, we sort of, so actually starting from Europe and thinking about how Europe's healthcare system and health infrastructure and politics of health operates is going to be helpful for us. So then we're going to have Salonee Bhaman, who is a PhD candidate at the Department of History and Program in Women, Gender, and Sexuality Studies. Her research focuses on histories of race, gender, social welfare, migration, and labor in the 20th century United States. Her dissertation is entitled The Borders of Care, Immigration, Welfare, and Intimacy in the Era of AIDS, and explores social provisions and struggles, movements for social provision in the politics of care work during the first years of the HIV epidemic. And then we have Julia Lynch, who's a professor of political science at the University of Pennsylvania.
You already talked about
me. Wait a second. Deborah Stone. You can see how my mind is.
I know, we're interchangeable, really.
So yeah. I mean, my order was wrong. Deborah Stone is a political scientist who specializes in health policy and social policy more generally. Deborah's taught at Duke, MIT, and Brandeis, where she's currently professor emerita, and has written some really important, formative, classic articles in health policy, including The Struggle for the Soul of Health Insurance, Beyond Moral Hazard, Insurance as Moral Opportunity, and Why We Need a Care Movement, and is working on some really interesting stuff now, including a book on counting. So I've said enough, so let me have Julia start us off.
Great. Well, thank you so much. I also want to say a heartfelt thanks to the folks at the LPE project for making this crazy, like, first in 2 years in-person gathering happen, and of course all of you for coming out. So we're thinking this evening about the connection between neoliberalism and healthcare, and I think that a lot of us who think about that connection are really concerned at the end of the day with health equity and with how neoliberalism can get in the way of creating a more equitable society more broadly. So I'm going to talk about some of these connections in the next few minutes, but first I want to ask, what do we mean when we talk about health equity? I'm going to start from the standpoint of European policymakers who have increasingly over the last 20 years come to view inequalities in health outcomes as the main form of health inequity that they're concerned about. So I'm going to be talking about health outcomes rather than access to health care as sort of the standard for health equity. And if sort of health outcomes of various kinds, whether it's morbidity, mortality, well-being, are differently distributed across groups in society in ways that we think are unfair, then we refer to that as health inequity. Now, health inequities in this view are caused by a mix of downstream, upstream, and more structural factors. Downstream factors are things that are very close to creating the actual health outcomes that we observe and can include things like access to healthcare, but also nutrition, occupational exposures, and the like. Further upstream factors might be things like education or income or the kinds of social networks that you have that are a little more distal to producing those health outcomes, but that are still obviously really connected to the outcomes that we observe. And then we can also think about structural causes, the political, commercial, and economic policy determinants of health, and other structural features like racism that can work through a variety of channels to affect health outcomes in different groups. Now, this is the way that most European policymakers have talked about health equity over the last 20, even 30 years. But until very recently, sort of lay definitions, the normal definitions that ordinary people would use to talk about health inequity in the United States were almost entirely linked to inequalities in access to healthcare. And of course, that makes sense because, unlike most countries in Western Europe, we haven't had universal access to healthcare, and they have. And so it makes sense that we would focus more on this. But it also means that there's been little awareness or concern about inequalities in health outcomes, particularly among white Americans. So if we look at survey research, it is the case that there is a sort of more recognition that inequalities in health outcomes exist among African Americans. And of course, as we've seen in Europe, there's sort of a widespread recognition that inequalities in health outcomes matter. Whereas in the United States, we really tend to think about it mostly in terms of health care. But even so, even when you move to Europe, healthcare is really at top of mind when most citizens and even when most policymakers and even when most health policymakers think about making health policy to reduce health inequities. So this was the case until pretty recently. So the dominant way of thinking about health inequalities is thinking about inequalities in access to healthcare. Well, starting in the 1990s in several European countries and continuing through the 2000s and the 2010s, there has been a transition among sort of center-left politicians to talking about health equity in terms of health outcomes as really a meaningful aspect of broader social inequality. So it's not just about access to care. Health outcomes, unequal health outcomes have come to be seen as sort of a marker of broader inequities. And I think around COVID, we are just starting to see that happen in the United States. And I'm going to come back to this point later. So why do we see this change? Well, with the rise of neoliberalism, beginning with sort of Reagan and Thatcher, but by the 1990s, really sort of becoming just the common language of political and policy elites across the political spectrum, center-left leaders who, for the most part, had sort of adopted many of the core tenets of neoliberalism, that markets were the best way to do things, that investment in human capital was the right way to think about sort of treating people well. These center-left leaders, well, first of all, were not necessarily winning. And secondly, they were sort of worried about losing their traditional working class base that really wanted them to be for inequality, even as they were reaching out to kind of new middle class voters who they perceived as being much more friendly to markets and not wanting to pay taxes and the like. So these center left leaders, they wanted to find a way to be for more inequality. But for more equal societies, for less inequality. Although one wonders sometimes. But they wanted to do it in a non-threatening way, in a way that was compatible with the reigning neoliberal orthodoxy among domestic and European Union level elites, and also with what they thought were the preferences of sort of middle-class electors. So how do you do this? You're a center-left party. At some level, you have to be for equality, but you don't really want to talk about things like redistribution, which are just kind of dangerous, and social spending and regulating markets and all of these things that have become sort of taboo. So increasingly, they started linking the issue of inequality, sort of broader social inequalities, to the idea of health, linking it to the issue of health inequalities. To do this, they drew on not thin air. They didn't just make this up. There had been a very kind of activist group of scholars, epidemiologists, public health scholars working through the European Regional Office of the World Health Organization. They had really been pushing for more recognition of the social determinants of health and of health inequalities as a policy problem. And this had really been accepted at the level of the European Union as sort of a good way to talk about the problem of inequality. So great, right? We're going to solve the problem of inequality. Awesome. Policy solution, what do? Well, there's this thing that, you know, by the 2010s, we're pretty universally calling health in all policies. And the idea is that what governments should do is they should work through, you know, multiple policy levers, recognizing that there are downstream, upstream, and more systemic factors that are causing inequalities. We should work across ministries, you know, work with the health ministry, but also work with transportation and social services and the labor ministry, but never finance, right? Never finance. So lots of cross-sectoral collaboration, very complex, technocratic, multi-level governance of all of the policy levers that you could think of as belonging to, you know, as affecting the social determinants of health, but never finance. So what happens is this policy solution of health in all policies, this complex technocratic policy solution gets adopted, and all of the social structural, far upstream determinants get dropped. So what we see is when these European policymakers start to re-envision social inequality as a problem of health inequity, we see a shift in the Overton window around the problem of inequality. So rather than being a problem for which you might use taxation, redistribution, regulation of product and service markets, you know, social spending to solve some of these problems, now we are doing health in all policies. And, you know, to cut to the punchline, it basically doesn't work. It's just too complicated. So it's not that these people didn't want to solve the problem, but the way that they reframed what the issue of inequality is made the problem basically too hard to solve. And I think, I can't remember what time we started. How much time do I have?
You probably maybe just take another 2 minutes.
Yeah, that's what I'll do.
Doable?
So what I want to ask is, you know, what if we did that here, right? Because we're now starting to really think about inequalities in health outcomes, particularly with COVID, as a fundamental problem of equity. And we are really starting to link some of these health outcomes to COVID. What if we took that seriously here? What would happen? So, you know, I think one possibility is that maybe we would succeed in explaining to people that unequal health outcomes actually really matter, that they're not just a matter of biology or personal behavior, which in many of the sort of survey research work that I've done in the past, I've found is the case. You know, maybe we'll explain to people that actually health outcomes are linked to something bigger that individuals don't control. But I have to say I'm not optimistic. So if we look at how COVID deaths are persistently framed as being linked to comorbidities or to people's failure to vaccinate, if we look at this fact, despite the fact that we know that these deaths are also strongly linked to vulnerabilities that are caused by structurally driven economic and political choices and by systemic racism, you know, I think it's not looking great. Now, what if we do somehow magically succeed in bringing more attention to the issue of health inequalities, you know, in a way that sort of manages to convince people that it's just not entirely the fault of people who are dying? Well, judging from the European experience, I think that a shift to talking about social equity and social inequity more broadly in terms of health outcomes is unlikely to produce a sea change in public willingness to deal with the problem of inequality. Why? Well, one reason is this shift in the Overton window around the problem of inequality that I've just described, but there are others. Right up until the pandemic, health in all policies seemed to be the policy solution that most progressive people interested in health equity were pushing in the US if they weren't just pushing for Medicare for all. there was no attention to the fact that it had been judged at best a highly qualified success and at worst a failure by close observers in the European countries and also in Australia, where it had been implemented quite thoroughly. Finally, I think that reframing health inequality from being an issue of healthcare access to an issue of unfair health outcomes not only goes against the grain of US public opinion, but it can also be used as a way to divert attention from the fact that you are defunding public healthcare services. Now, I think this does not seem far-fetched to an American audience, but I would like you to know that this has happened in Europe too. This is how French politicians have used the issue of health inequalities. They have used it as an excuse to spend less money on healthcare. If we do more on primary prevention and social determinants of health, it costs us as the healthcare system less. And so, yes, let's do that. But even in the UK, at the height of concern over health inequalities, the Black Report, the seminal report that kicked off all of Europe's attention to the problem of health inequalities, was delayed for several months because of a disagreement in the committee about whether the report could be used as an excuse to cut funding of the NHS. They delayed it so that instead of landing on the desk of a labor minister who would have implemented it, it landed on the desk of Margaret Thatcher's minister. So I'm going to stop there because I think it provides a nice lead into the issue of health services, access, and insurance that the next two speakers are going to talk about.
Thank you. Thank you. Am I next?
Yes.
Great. So I will echo the thanks to the LPE project and Sarah and Corinne, and Greg and Amy. I'm so excited to be here. As mentioned, I am a historian, and I'm currently working on a project about the political economy of the first decades of the HIV/AIDS epidemic in the United States, which is in many ways a political economy of neoliberalism and healthcare at the end of the 20th century. Is kind of a perfectly wrapped up case study. And because I'm a historian, I wanted to begin by talking about one of the really illustrative case studies in my project and what it might kind of tell us if we unravel it a little bit about the underlying logic and construction of the public-private healthcare system and its infrastructure in the United States. So my study begins with Don Hoffman. Don Hoffman was diagnosed with AIDS in 1990 when he was 30 years old. At the time, he worked at the Sheraton Inn in Milwaukee, and it was a job with benefits, including participation in an employer-sponsored group health insurance plan. Thanks to COBRA, which was passed in 1986, Hoffman was able to continue his coverage under his original group plan when he became too sick to work. He just had to pay his own monthly premiums in order to do so and retain his coverage. And that was a really good thing because his health insurance plan entitled him to a lifetime total of $1 million in coverage. That was really important because Hoffman suddenly had many major medical bills and was unable to work. The state of Wisconsin also had an interest in Hoffman's kind of continuing ability to access his private insurance and offered to pay his COBRA premiums in order for him to remain privately insured rather than on the Medicaid rolls. However, about a year into his illness, the Sheraton Inn was purchased by a large hotel conglomerate. And one of the things that they did was they converted the original health insurance coverage into a self-funded model. Under the court's interpretation of ERISA, or the Employment, Retirement, and Insurance Security Act, a federal law that preempted state policy, which I'm sure many of you lawyers are fully familiar with, that meant that the new plan didn't have to adhere to a law that was specific to Wisconsin that prevented health insurers from denying or modifying coverage for an individual who tested positive for HIV. Hoffman had been receiving treatment for his illness for many years, or for just about a year. And as a result, his COBRA premiums doubled and his coverage was now capped at $10,000 over his entire lifetime. That was about how much Don spent on medical bills in a year. So it was a very different issue. His HIV status also made him nearly uninsurable were he to try to secure an individual private insurance plan or try to join another group plan. And so ultimately, Don Hoffman had no choice but to spend down his limited savings and assets in order to qualify for Medicaid, meaning that he would have to really sell all his belongings, divest from any property he owned. He wasn't allowed to own a car, things like that. His predicament really reflected a larger battle between private insurers, state officials, and AIDS advocates grappling with the costs of a highly stigmatized chronic illness within the patchwork of a public-private healthcare system. And as I mentioned, I think if we kind of unravel what happens to Hoffman, we can kind of learn a lot about some of what's happening with healthcare at this crucial moment. I found Hoffman's story while trying to kind of untangle the regulatory infrastructure of HIV testing and private insurance. And for those of you who aren't experts in this history, which intimidatingly several people are, the first blood tests which screened for HIV, known as the ELISA tests, became widely available in 1985. Almost immediately, they spurred a great deal of debate among insurers and healthcare providers and state lawmakers. And predictably, privacy protections and fears of discrimination were at the heart of those debates. Those concerns were germane in many areas, from housing to immigration, but private insurance is a really interesting one for our discussion today, because almost as soon as the ELISA test became available, it became used in evaluating health insurance applications and as a screening tool for private insurers. And many with HIV were essentially considered uninsurable by most healthcare providers. It also dovetailed really interestingly with employment discrimination allegations, because many private employers didn't want to employ people who would be very expensive to insure. In the face of activist pressure, I found that most state lawmakers, particularly in California, Washington, D.C., Florida, and Milwaukee, or Wisconsin, were willing to advocate to pass legislation barring insurance companies from using HIV tests as a means of excluding people from coverage in group plans. This might be kind of surprising given the stigma surrounding HIV/AIDS, but it's less surprising when we consider the fact that state Medicare and Medicaid bureaucracies essentially became the insurers of last resort for those people who relied on private health insurance. Those state regulators were motivated in all likelihood by the strain the private divestiture from the cost of caring for people with AIDS would place on an already strained public healthcare infrastructure. Insurance companies, however, pushed back almost immediately, using a logic that historian Hallie Horan kind of has termed actuarial fairness, that it would be unfair to include people with high costs of care in normal risk pools, because it would artificially inflate the cost of insurance for people who are healthy, and force insurance companies to deny members on less finely hewn proxies. So basically, if insurance companies were not allowed to test for HIV, they would have no choice but to exclude people based on the fact that they were single men who lived in cities, or they listed non-family members as insurance beneficiaries, things that were obviously discriminatory in the law. And this tug of war between state legislatures who were eager to minimize the burden on public resources and insurers committed to particular modes of screening that prioritize profit and actuarial science, which is a term that comes up a lot in my research, give us a sense of some of the incentives that undergirded these political economic questions. Both lawmakers and insurers, however, also shared a common belief that costs related to AIDS care would be quote unquote catastrophic if unmitigated. And I kind of want to tentatively suggest that while that belief was rooted in part in the realities of treating and diagnosing an under-researched and highly stigmatized illness, it was also rooted in the way that healthcare financing operated. In particular, many hospitals and insurance systems were constrained by the DRG system, or the Diagnosis Related Group system, which was a set of 500 conditions. It's a system that was actually developed at Yale by a Yale School of Management professor and public health school professor that essentially reimbursed based on the average of how much a disease costs to treat, rather than the actual costs of treating a particular person. So it's a healthcare model that's kind of prioritizing a certain statistical regularity, efficiency, but there was no DRG category for many AIDS-related conditions. And so overwhelmingly, public hospitals were forced to list patients in a mismatch of other categories that left them unreimbursed for many of those costs of care. As those already very strained public hospitals, which have been systematically defunded over the course of the previous decades, struggled to make use of their limited beds, the kind of catastrophic cost of AIDS care became an almost rhetorical device that insurers and public officials could use to deny health coverage based on sort of a moral hazard philosophy. Some people had been deserving of destitution because they had essentially taken on too much risk to be safely insured. I also think, and I'll talk about this really briefly, that this sort of conundrum brings up a lot of interesting questions around the implication that healthcare is fundamentally tied to employment in this country. And healthcare access is first and foremost a benefit that private healthcare access anyway, that comes alongside particular forms of labor. So of course, employer-sponsored group health insurance plans really become popular in the 1920s and 30s, and they become increasingly codified in the New Deal order, essentially tying the ability to access care to the capacity to perform certain kinds of labor. Preemptions like the ERISA preemption occupy an interesting place in this history, as they're really supported by organized labor attempting to keep states from implementing minimum standards of care that would interfere with collective bargaining rights or the ability of certain industries, particularly mining, shipping, and garments, to prevent states from mandating benefits that might change the amount of salary or other kind of things that were supposed to be under union control as bargaining tools. This case study is also useful because it dovetails with the conservative political shift towards mandated work requirements or workfare provisions that we see elsewhere in the kind of welfare state apparatus that tie access to state-sponsored benefits for all sorts of things, from food stamps to AFDC, with also the ability to work or the willingness to work, all sorts of kind of behavioral coercions. And I think both of those questions essentially become deeply rooted in a racialized discourse around fraud, worthiness, means testing that undergird many of our social insurance policies today. And I think that's kind of firmly also in a conversation about neoliberalism. When Don Hoffman had to spend down or endure a 2-year mandatory waiting period before he could qualify for Medicare, it was essentially a punitive measure that forced him to perform a certain kind of destitution before he was able to be cared for. During a time where the average life expectancy for someone with an AIDS diagnosis was about 18 months, a 2-year waiting period is essentially abandonment by the state. It's organized neglect. And I think that here's where sort of looking at some of the work that disability rights organizers and people who've done work around poverty and inequality is a really helpful place to begin when we start to think about how to move forward. I also think that the Hoffman case study tells us a lot about the granular way that federalization of state power really functioned. And historians think a lot about what federalization really meant, whether it's some kind of move towards block grants for Medicare funding or welfare spending. But I think it shows us how the law is actually constructed in a way that allowed private insurers to offer, on one hand, uniform benefits at a national level, while being unaccountable to any one system. And it's also here that I think looking at the work that activists did is really important and offers us some sort of brief moments of possibility. Activists actually often targeted specific, I'll pause for a second, I'm talking very fast, but while there's no national sort of insurance regulation, every state has an individual insurance commissioner. And something that activists often found that is if they targeted individual insurance bureaucracies at the state level, they were able to compel change by winning just one case of maybe 13 that they brought. And that would compel a larger change because most health insurance policies were constructed in a uniform way at the national level. So one victory in a statistically significant place might result in a cascading policy change around the country. And I'll kind of conclude by saying the activist responses to this crisis were unique and profound and often entailed people from within the insurance industry. I study one group called the Concerned Insurance Professionals for Human Rights that were really instrumental in sort of mitigating some of the effects of HIV testing policies. And many of those people were just insurance professionals who saw what was happening in the industry and were proposing increasingly kind of technocratic solutions from knowing what insurance looked like. And also involved a lot of coalitional work between AIDS advocates and other people representing chronic illness communities or disability communities. And most of the solutions that they were able to negotiate with state and federal governments were rooted in activists becoming experts in how the insurance industry functioned. The recommendations were varied, but they included establishing state subsidized high risk pools, special drug programs, managed care programs, and specialized healthcare financing. And as we kind of look at all of those things, I do want to emphasize that that work was strategic and significant within a particular context, a context of urgent need. But with that said, I think it also occurred within an insurance framework that accepted particular ideas of risk or fairness. The table stakes of insurance provision didn't really change. And with respect to the theme of this panel, I think that making universal claims and creating universal solutions might require us to think more broadly and expansively beyond a framework where there is a moral hazard that is sort of morally just or makes sense. And beyond being rooted in actuarial fairness or risk management is actually rooted in claims of kind of universal deservingness, for lack of a better way of putting it. Thank you.
Wow. Amazing. It is a tour de force of insurance education. So thank you all, the LPE group, for inviting me, and thanks to the powers that be at Yale that allowed us to have this in person. I think we were all talking before, it's our first in-person conference in 2 years. And it's just, I feel somewhat like I'm on a first date. So, and thanks to Julie and Salonee, we didn't plan this, but Salonee, so that both actually gave great introductions to, so that I won't have to say as much. I want to start out by giving my definition of neoliberalism, which is a little bit, I think, more pointed than yours. I would say that neoliberalism is not primarily a set of ideas. It's primarily a system of governance in which money holds the power. And as a set of ideas, neoliberalism is simply the way the owners of capital justify their political domination by making it seem good for everybody. With that as my starting point, I want to talk about a presumption that we all share and that was actually part of the call for this panel, that ideas are powerful and that reframing an issue or a conflict is a key tool for achieving the policy change you want. But it's clear, as Julie talked about, that reframing hasn't worked in health policy. I will explore this failure by looking at two concepts the left tried to reframe, the concept of health and the concept of insurance. And like Julie, I want to ask, what happened? What went wrong? And I'm going to give you my answer now, so in case you're feeling desperate, you can go get a cup of coffee. Basically, big money readily absorbed each new way of framing. Corporations and financiers and the owners of capital not only absorb new frames, but refashioned them into tools for their own advantage. It was never a battle of ideas. Big money actively prevented serious policy change because it had the power to get its own way. Bottom line, we're not going to be able to change the course of policy by reframing. Give it up. At least for now. We need to recapture the machinery of policymaking. Okay, to start with health. Public health advocates have been arguing for a long time that health is determined not so much by medical care as by large societal factors, principally nutrition, education, housing, income, wealth, social connection, and perhaps most important, being treated as a full member of your community, being treated with respect and dignity as opposed to disdain and discrimination and exclusion. The new frame went under the label social determinants of health, which, as Julie shows so nicely in her book, is really a politically acceptable milquetoast phrase to not talk about political economy or redistribution of power and money. It became very easy to, with that framing, it became very easy to individualize the solution. Each complex causal factor became an individual lifestyle choice. Let's just look at food and nutrition. Under the new frame, some food assistance programs were strengthened, But the main policy thrust prompted by the new frame was labeling food containers with their nutrients and educating consumers to read the labels and make informed, healthy choices. None of that made a dent in food processing or in the salt and sugar and additives that addict people to unhealthy food. The best way I could explain what went down in nutrition policy is with a story I read in the Wall Street Journal about 12 or 13 years ago. It was a series the Wall Street Journal ran on obesity and the causes of obesity. In one story, the reporter interviewed a Puerto Rican woman who had recently immigrated to Chicago, maybe been there for about a year and a half. And she explained that instead of eating what had been their traditional diet in Puerto Rico, beans and rice, vegetables, pork and fish, which nutritionists consider a very healthy way to eat, they now like to eat pizza, hot dogs, hamburgers, soda pop, and ice cream. And they go to fast food places as often as they can. And the reporter asked why, and the woman said, "We feel good when we go to these places. We feel like we're Americans, that we're here and we belong here." This story carries a powerful lesson for those of us who would try to fight with ideas. The profit-making food industry was able to make a profound change in the culture of food that overwhelms any nutrition science and education. By culture of food, I mean what kind of food people consider good and tasty, and what kind of food provides them with social status and a sense of belonging. Those symbolic benefits of food matter so much more to people than the percentage daily value of proteins and carbs and so forth. Science education and nutrition labeling don't stand a chance against the culture of food produced by big industry. And now to insurance. The advocates of universal health insurance have tried mightily to reframe how people understand health insurance. I want to illustrate this failure with a story of the strange career of the term pre-existing condition. It really evolved through several reframing jobs. Let me show you what these were. For a long time, pre-existing condition was insider jargon in the insurance industry for a reason to deny people insurance coverage. Commercial insurers can't make a profit if they insure people who are already sick or have a high likelihood of getting sick. So they use medical screening and other prediction tools to identify bad risks like HIV and either exclude people who have those or charge them more for insurance. All this internal operation was quite secret, unknown until the HIV epidemic. In 1985, when I think slightly before that, the virus was identified, several groups were named as high-risk groups, principally gays originally. And in 1985, the first antibody test became available. Immediately, health and life insurers announced en bloc that they would test applicants for health and life insurance for HIV, would exclude anyone who tested positive, and they would also exclude or deny insurance to anybody belonging to the identified high-risk groups. There was a major outcry, especially from the gay community, which fought for banning HIV testing and in some states successfully. But industry fought back with a public marketing campaign about how insurance works. The industry said, since insurance is a vehicle for paying for medical care, it's only fair that people who have higher risk of getting sick and will use more medical care should pay more than people who are healthy. And besides, insurers can't remain financially solvent if they have to cover people with high medical expenses. And particularly in the 1980s, the cost of HIV care was just staggering. It was all done in hospitals. And the insurers didn't even consider maybe covering care in less expensive places. Here was a prime example of capital using ideas to justify its dominance. It's structuring insurance to keep its own profit rather than do what insurance is supposed to do, is help people get healthcare. Then the left got hold of the term pre-existing condition. Clinton and Obama each used that term as a rallying cry against private insurers to gain support for their national insurance proposals. Obama repeatedly, when he was campaigning in his first campaign, he repeatedly told the story about his mother who had had breast cancer and was now denied health insurance coverage. Obama made the term pre-existing condition symbolize an industry that was unfair, even barbaric. Still, this new reframing of insurance is something that should be socially inclusive, totally failed. Obama couldn't even get Jacob Hacker, Yale professor you probably know. Jacob Hacker came up with a brilliant idea of a public option, a kind of social insurance that would be available to anybody on the ACA health insurance market if they chose it. And Obama couldn't even get that as a tiny sliver of the health insurance market. The Clinton and Obama reforms, especially the ACA, expanded the number of people with health insurance, but they did it by expanding the customer base for private insurers with government subsidies. The reframing failed, not because solidarity isn't an appealing idea, but because the insurance industry has tons of money. It funds political campaigns, it lobbies, and it can buy the laws it wants and effectively veto the regulation it doesn't want. To take one example, Medicare Part D prescription drug coverage could pass only if Medicare was prohibited from negotiating bulk discounts on prescription drugs. The evolution of the term pre-existing condition gets even creepier. It went from a term of accusation against commercial insurers to a popular synonym for any illness. How many of you have heard people say, I have a pre-existing condition? Or maybe you've said it yourself. Yeah. During the pandemic, Republicans and Trumpers weaponized this new popular meaning to resist the deep structural changes that COVID showed are necessary. They said, COVID isn't so bad. Most people who died of it had pre-existing conditions, as if that makes their deaths more acceptable, almost normal. Public policy, they said, should only worry about the strong people who don't have pre-existing conditions and not shut down the economy to protect weak people who are going to die soon anyway. Thus, big money was able to neutralize a term that had once been its shame and the mobilizing tool of universal insurance advocates. Worse than neutralize, big money converted the term into a weapon against public health measures that would hurt their portfolios. The lesson of COVID for us health policy advocates is stark. We should put a pause on trying to reframe and reform health policy and dedicate ourselves to reclaiming democracy. In the US, big money and its Republican allies are locked into their worldview and have a lock on the policy machinery at the federal and most state levels. Reframing can't begin to weaken the juggernaut of financiers, private insurance, and big pharma, even when reframing is backed by a social movement. I'm not saying stop re-envisioning and trying to reform health policy forever, but now we need all hands on deck to rescue democracy. That means more than just voting or even working to get out the vote. It means do whatever you can to preserve election integrity, however and wherever you can.
So I think I'll maybe start us off with the first question, but inviting folks online to put questions into the Q&A, and all of you to just use your old-fashioned hands and stick your hand up, and we'll call on you, and you'll speak without unmuting yourself. You'll just speak. It'll be great. So this was, first of all, wonderful, and I think where we want to go is towards the question of sort of how do we use this in, like, to sort of tell us what to do next, which is sort of where we ended. Because there's a lot of darkness in what you guys have described. So starting with, as I said at the outset, you could imagine maybe if we just got to Denmark, right? We could just get to Denmark where there's, or some European imagined, universal healthcare and some form of commitment, at least to health equity. We would sort of pretty dark conception of what I think many advocates who care deeply about health inequity and health outcomes as have before them. And your kind of emphasis on framing and the difficulties of framing in a way that will actually be, the impossibility of framing in a way that would be immune to the power of money in politics to just simply deflect and reverse the reframing. And Salonee, maybe you have a little bit of there's movements going, and so there's something a little bit more hopeful going on. But I guess I wanted to invite you guys to say whatever you might want to add about sort of how you think the things you said would, where you ended, I guess, Deborah, tell us about where to go next, right? And maybe one piece that I wanted to maybe resist a little bit would be, can we even separate questions about taking back democratic power and building movement power, which I'm absolutely delighted is where we ended up, and a very comfortable place to be in a law school, actually, from questions about the ideas and the frames that we use to sort of mobilize people, right? Because organizing is hard. You have to get people, and taking back political power is hard. You have to get people excited about what it is that you are, in fact, trying to, why are you coming to the polls? Why are you voting for this party instead of that party? And so do you see the sort of an interaction between, or any kind of possibilities since we started with health and health equity, Medicare for all, are those mobilizing tools potentially, or are they only always going to collapse back into the doctors will take over, the health insurance companies will take over, and there isn't going to be any more space there left for kind of, or couldn't be synergistic with movement mobilizing? Does that make sense?
I have some thoughts.
Great.
So I think a first thought is, as usual, Deborah and I are in violent agreement. And yeah, we are never going to win the framing game because the other side has way more money and frankly, much better, consultants than we do. So, but that doesn't mean that we don't have to think hard about how we communicate with people about what our goals are and where we want to go. So it may never be enough, but we still have to do it because what other choice do we have? And so when I think about the work that I've done, not only on sort of public attitudes towards health inequalities in the US, but also a lot of conversations that I had with politicians in Europe, one of the things that really comes to the front of mind for me is a guy who was an MP in England who represented a very poor district in the north of England. And this is a guy who, was a natural to be running on the issue of health inequalities. If anybody could make this work, he could. The people in his district have terrible life expectancy. Their lives were scarred by disability from a really young age. And he said, this is a terrible issue for me. First of all, I'm walking around telling my constituents, you're all gonna die. And then, in addition to which, they identify me with sort of public health, which means me taking away your few small pleasures. Smoking, eating junk food, eating stuff that you know, that tastes delicious and that actually does sort of push back the depression of everyday life momentarily. Like, we know this, right? It works. And in a time and a place where really people have very few other options. And so he said, I'm not going to touch this. Like, I don't want to touch this issue with a 10-foot pole. And yet he was the shadow minister for health in the Labor government. So I think we do have to think really hard to avoid, you know, if we're going to take on health as an issue, if we believe that people have a right to health, if we believe that health is important to people, if we believe that, you know, this mass disabling event that we're going through right now is going to have significant repercussions for us, we need to find a way to talk to people about health and to try to mobilize them around health that isn't depressing and demobilizing. So yes, the other side is always going to win when it comes to framing, but we've got to start somewhere. And so starting somewhere is taking a really hard look at how do we talk about health as an issue that is capable of mobilizing people. And, you know, I have thoughts about that, but I'm sure that these two do as well. So I will pass the issue along to them.
Yeah, I have a thought, and that, well, I'm kind of reminded immediately by an oral history. For those of you who are interested in sort of social mobilization and social movement history, I cannot recommend the ACT UP oral history series enough. Sarah Schulman just came up with a big book too, if you want it bound and nicely edited for you. But there's an activist, Karen Timor, who was on ACT UP New York's insurance committee, who said that initially when you start talking about insurance, it's very boring. But once you get people talking about it, they won't shut up about it because everyone is sort of radicalized by talking about their own experience navigating accessing healthcare. And if you've ever had a claim denied or some sort of Kafka-esque phone call with even Yale Health, you know that it's a mobilizing force, right? So I think some of it is in the devil's in the details. And I think that is where the logics of the industry become most bizarre and obvious to people as something that needs to change. Because I'm writing a dissertation, I also think a lot about the same things over and over again. And I think that harm reduction philosophy has actually been a really useful way when I think about how to talk to people about health, because I think so much of our kind of health conversation can be shaming or stigmatizing in many different ways, whether that's about drug use or smoking or eating badly or things that people don't have a lot of control over in their day-to-day lives. And I think anything that can reframe healthcare as something that is not exclusively the provenance of experts who are kind of delivering information from on high is useful. And I think based on this COVID moment, I think that the Great Resignation and our quest for a more democratized healthcare system are related. I think that the sort of acceptance of that work-related healthcare coverage paradigm is going to need to shift. And I think we have some, maybe I'm just constantly looking for silver linings, but I think we have some really good examples of what state-sponsored mass healthcare can look like when we think about Javits Center being turned into a mass vaccination clinic, or how easy it was to get a COVID test for brief moments of time in New York City. It was, yeah, free. You don't need to put down your insurance card on every corner. Obviously there were, you know, moments of more friction than that, but I think it was a moment where Health and Hospitals Corporation was providing you better healthcare than your Walgreens or your Rite Aid. And I think that's a living example of how people can imagine a public healthcare system that isn't kind of full of the boogeyman of what public healthcare might look like. And so it does seem like a profound opportunity, but probably a more uphill battle than just that framing allows for.
As I think about this, I think I think it probably is possible to mobilize people around health issues, and but what good does it do if you get them caring about whatever, you know, more access to insurance, more free care, whatever, better employment, you know, paid medical leave, paid family care, and so on. What good is it if they're denied the right to vote? Whatever issues you get them excited about, if states are cutting back, like Texas, cutting back opportunities to vote, making it really difficult for precisely the constituencies that we're most able to mobilize around health issues to get to the polls. And then changing the rules on how ballots are counted and so on. I'm just wondering how effective this mobilizing can be. And I think about, COVID, I mean, it is really a crisis, more, than anything. Yeah, I don't need to say more about that, but we've got this huge crisis, and it's so clear that you need an active government to deal with anything of this magnitude. And yet Congress is on life support. We can't get anything passed in Congress, anything decent that we are, right? And the Supreme Court is, yeah, I don't even want to go there. And usually crisis has been the thing that brings makes social movements effective and makes leaders capitulate. But because our institutions are broken, I'm just wondering, I mean, they've shown that they can't respond to the crisis. So I'm sorry, I'm not giving you what we do next, but I'm stymied, and the only thing I can think of is to say we've got to go state by state and fix the election system.
It's unfortunately not a state by state problem only though, right? It's the Senate, it's the Electoral College, it's the Supreme Court. Okay, so it gets bigger. Great. So there's a couple of questions online, and I think I might just because there's a few there, take one of those first and then come to the room. Okay. The first question online: as time goes on, I'm coming to the conclusion that the market is the fundamental obstacle in the way of achieving healthcare equity. To what extent do you advocate for the abolition of markets in the healthcare space? And I guess maybe instead of having everybody answer each question, right? Like if you feel moved to answer that question, offer yourself up. Do you advocate for the abolition of markets in the healthcare space?
I actually don't. As someone who has studied a variety of healthcare systems organized in a variety of different ways with a variety of different market and non-market mechanisms operating in a variety of different parts of the healthcare system, I don't think it makes a damn bit of difference whether you have markets or some other allocation mechanism taking place. If you don't first agree as a society that everybody has a right to access this service, it doesn't matter how you organize it. And it also, if you agree as a society that everyone has a right to this, they're really, I hate to be that person who says that markets are fine because, I'm not that person, right? But the fact is that markets are fine. Like markets can do healthcare just as states can do healthcare. Like I don't see that we should automatically prioritize bureaucracies, states versus markets here. My experience and my knowledge of a wide variety of healthcare systems suggests to me that that is not the issue.
I'm going to contest that a little bit in this, in the sense that I think healthcare is a space where what the market actually is completely unclear, right? I mean, many of the contexts in which we're talking about, where there's like a commitment to universal health insurance, that the state is in fact in one way or another in Western Europe sort of funding.
Mm-hmm.
They're not markets in the conventional sense of market.
Yeah, but neither is ours.
Well, right. but what I guess I'm saying is I think there's a way in which healthcare to be organized the way you're describing is a commitment to everyone. Can't be a market in the way that people think markets are.
It's a highly regulated form of market.
It's a highly regulated form of markets. And then I do think that the way that you regulate the market can have tremendous implications for how much you can make available within the public health system.
But
if you don't have the commitment to universal care, you're gonna, you're not gonna get it. But my work is mostly on pharma, where Western Europe is running into all kinds of trouble because they've adopted a particular kind of way of thinking about markets. It's regulated, but against the backdrop of lots of monopoly power of the industry,
Right.
where they have a lot of trouble figuring out how to lower prices enough. And that's fundamentally, in my view, about a certain kind of market structure that they have accepted, where the industry still has fundamentally a ton of power in price setting, because they can say, we're not going to sell that drug into your country.
Right,
And we won't touch it because we don't override patents or figure out like a
Right.
more muscular way to control prices. And so like, I actually think the market structure matters a lot. And we should just recognize healthcare as a space that already doesn't have markets in a conventional sense. And still take your point, which is that there's a lot of different ways one can organize lots of pieces of the healthcare system that might not look like the NHS and still provide lots of good healthcare. for
my
people.
point is that there's no such thing as a market, right? All markets are regulated, all markets are unregulated in some ways. And so what is really critical is, how do you regulate that market? So one option is to just get rid of the market, but even the NHS has lots of market mechanisms in it. And so you're never gonna do away with markets. So instead, I think what we should be thinking about is, how do we want to regulate markets, not should we have a market or not have a market. I think we're in agreement in some sense.
I think, yeah, well, and it gets to like really interesting questions about like what do we actually mean by market? Sometimes people like think that competition, like anything with competition is a
Right.
market. And some people think that anything with prices is a market. And so there's actually like a kind of deep, interesting question about what we think markets are. All right, I'm gonna come to the room for a question in there.
Yeah, thank you all so much for speaking with us. I really appreciated what you said, Dr. Stone, about how we won't be able to change policy by reframing and reforming. And that's kind of what we're learning about in a lot of our health policy classes, about how the sheer scale of the US healthcare system and like our current political arena is making it so difficult to fundamentally change. And so we're learning about a lot of these like gradual incremental reforms with like discrete issue areas like having provider prices and addressing like hospital consolidation. And so I was just wondering what any of you thought about like the value of these small but tangible steps in the journey to the long-term goal of universal healthcare, or if this like kind of detracts our focus away from dismantling like the underlying neoliberal structure.
That's a good question. I have a thought, but I don't know is my answer, because I think that to some degree, it kind of creates that subsidized market that we are maybe dancing around a little bit. And one of the examples I'm thinking about a lot right now is the Ryan White Care Act, which was this kind of, massive and life-saving pool of funding that has been renewed several times, but is structured not as a healthcare entitlement program, but rather a special funding measure. So while it injected a lot of money for AIDS care into the market and offered some sort of real tangible state support to highly affected areas, it's kind of structured like a disaster relief bill rather than a healthcare bill. It essentially, it's almost like I think of it like when you have a broken bone or something and then it heals in a weird way. It's kind of doing that with the healthcare system. And a example that's particularly vivid in my mind is we have different Medicaid eligibility for the continental United States and Puerto Rico. And so you're entitled to a lot fewer benefits, particularly around the kind of HIV/AIDS medications you can get if you live in Puerto Rico and access Medicaid there. And so there was kind of an informal medical bridge, an air bridge that's created between Puerto Rico and New York, and people are using it to access healthcare. And what the Ryan White Care Act does is essentially creates state funding to allow people to access that air bridge more easily, which is fundamentally not addressing the kind of neo-colonial problem we see with that, but allows it to become less of a crisis. And so, but I really struggle by saying it's just a Band-Aid and so we shouldn't go for that solution, because those are real lives. And I think that that's sort of where I struggle for a political answer that is consistent. Yeah, if anyone else wants to address it too.
Yeah, I would say absolutely, work for incremental reforms, especially at local levels, because they make a difference to people, and it's easier to have an impact at a smaller level. And I'm not, there's some people who've argued, well, you should not do these Band-Aids. You should just let the wound get worse and worse, but then bring the system to a crisis. And there's people's lives at stake, and and suffering at stake for that. I'm not a fan of that, that strategy. and yet, I think at the same time, I mean, we need to fix the policymaking system and, politics, just because we need to, it's too big of a, health is too big of a problem, and healthcare is too big of a system to just think that you can do a patchwork by getting better services in New Haven. So,
I'm going to take one more quick one from here and then come back to the room. And so this is, I think, one-upping you, Deborah. This is the anonymous attendee who says, how much of the answer to a neoliberal healthcare system lies in setting up alternate systems? The right to vote in electoral politics can only provide a solution if elected leaders are actually responsive to the needs of the electorate, and we know they're not. So I think sort of some skepticism.
That just went too fast.
Oh, sorry. So I think that the core of it is the right to vote in electoral politics can only provide a solution if electoral leaders are actually responsive to the needs of the electorate. So don't we instead need to think about setting up alternate systems, for example, answering the problems of the neoliberal healthcare system by setting up alternate systems. So what if politics itself doesn't even work? I think is the sort of, as we know, leaders aren't responsive actually to the needs of the electorate.
Yeah, there are places in the US is one of them where people have set up para systems, so alternative systems, and they.
We actually had a panel about some of the social movement kind of histories here, right? The sort of free clinics the Black Panthers created, and there's a whole history of that actually. I don't know if that's part of what you're thinking of.
Yeah. But again, to me, it seems like our national government is a captive of big money, money interest, and also white supremacists. It's not just the appeal of the right now is not, it's not just people with money, it's a lot of working class and middle class people who somehow feel threatened by liberal inclusive values. So I think those problems need to be addressed.
Can I try to inject a little hope? So I think, not only can we walk and chew gum at the same time, like not only can we fight for democracy and also fight for a more just healthcare system, but we really need to. And it's not just because people's lives and suffering is at stake. It's because people need to practice being empowered in order to take on the bigger structures. And so I think from a movement building perspective, it's really, really important to work on the small, small from a systemic perspective, but really big from the point of view of the impact on individual people's lives. It's just critical to keep doing that work.
Yeah, let me, there's two questions I see over here, so let me take them. We'll take them together and then we'll have time to come back to the panel.
I was really struck by what you shared, Dr. Stone, about how powerful the insurance companies' lobbyists are. And I feel like that maybe supports the point of the online commenter who brought up the risk of our elected officials not acting on the public's best interests because of this huge big money sway. And it's making me wonder whether there's any way we can somehow incentivize insurance companies to care more about public health and to use their lobbying power and big money to push for some of the structural changes that we all know are needed. And I know this is the creative imagining, but would that world be possible? Like since changing our system of insurance seems insurmountable, and the need is for a greater focus on public health and addressing the structural changes, is there some way we can incentivize insurance companies or somehow include public health under their umbrella of what gets funded?
It's a really great question. a while back, I mean, I got to know people in the insurance industry when I was doing research on insurance, and there's a group called the National Academy of Social Insurance, which was created by people advocating for social insurance. And eventually they decided that they couldn't do it alone, and that they needed the insurance industry, the private industry as allies, and so invited many of them to become representatives, to become members of this organization. And I think they were, I was very upset about that move, because I thought this is supposed to be advocating for social insurance. That's why we all got together and made this organization. And then we're getting in bed with the enemy, you know. So, but I really did think that there are people in the industry who care about public health or the public's well-being or whatever. It's still, and I think that there should be ways to make private insurers realize that they can participate in social insurance and fully inclusive insurance that doesn't use actuarial rating and doesn't use pre-existing condition exclusions, and still make money. But it's tough. I mean, I think appealing to the better nature, you know, the angels of our better nature is a place to start, but I'm not sure what to do more than that. I like the idea. It's a good.
Just looking at some of the questions online, I think people are not ready to give up on the idea of universal health insurance and at least shrinking the private health insurance system to the size of a bathtub. Is that the Grover Norquist reference that I covered?
Yeah.
Okay, last question.
Yeah, so thanks so much for being here. It's great to have you in person, although I think I should have came through that door, because I think I could have snuck a few cookies in the past.
Definitely sneak them on your way out.
All right, I will. And we just talked about how hard it is to change kind of our insurance system and dynamics. Do you think that Medicaid and Medicare, passing them in the 1960s, did more to entrench poverty and to entrench white supremacist structures? Or do you think it set a path more to elimination of poverty, the improvement of health outcomes, and more of the incremental process of achieving those things that those kind of architects envisioned at the time?
Can I ask for a clarification?
Yes.
So are you asking whether we would have sort of gone further down the road of addressing poverty and unequal access to healthcare and all sorts of other bad stuff if we had sort of not put the Band-Aid on the wound with Medicare and Medicaid? You know, sort of let things get really bad and then get to a revolutionary moment? Or are you asking, like, did they actually help?
Yeah, I want to hear just, I guess if it was 1964 and you know what you know now, 60 years later, I think, right, they were trying to push for national health insurance, and the plan was to get there. And Bill Clinton tried, right, to finish that step. And we tried this whole incremental process for so long, but I mean, we had made progress in improving health outcomes and some metrics in Medicaid populations, but are those just crumbs in the grand scheme of things? And was there other ways to get better improvements in poverty and equitable health outcomes and access and going through kind of that piecemeal strategy?
There's no question that Medicaid particularly, and also Medicare, have made enormous improvements for enormous numbers of people. And Medicaid doesn't just cover very poor people. It also covers people with disabilities. It covers a lot of elderly people who can't pay enough for, for Medicare and so on. So absolutely, they've done a tremendous amount both to improve health and to alleviate some poverty. And I don't think it was politically, you said it yourself, it was not politically possible to get universal health insurance either in the 1960s or several earlier efforts that were tried. And it wasn't politically possible under Clinton and Obama. I think one hopeful thing to me, to come back to your question about could you get the insurance industry on board, was when Obama won, within 2 weeks, and he had talked about doing away with pre-existing conditions and actuarial rating. And within 2 weeks of his electoral victory, the first one, the insurance industry sent a memo to the White House saying, basically, we give up. We will agree to a social insurance system as long as there is a mandate for everybody to participate. And because they understood adverse selection means only healthy people, if there's not a mandate, only healthy people, only sick people will buy insurance. And they can't make money that way. But they said, we'll go with universal insurance if you make a mandate. And in fact, some actuarial rating was cut back and pre-existing, condition exclusion. So
Did any of those Western European countries get to universal health insurance through that piecemeal strategy, or is it all kind of post-World War II?
well, the ones I know, but I did my dissertation on the German health insurance system, which started in 1894, and it started only for workers. But it's most of the European countries Western European countries have universal health insurance, and private insurance was added on later for rich people. They could buy it in addition to, but everybody in Germany, Denmark, Sweden, wherever is required to participate in the social insurance system.
I wanted to say one thing. Did you want to say something, Salonee?
I was gonna say, I think I think that the expansion of Medicaid and Medicare were some of the most profound shifts in health equity and access in the 20th century. And they were unequivocally good things when they were passed. And then they were attacked systematically every single year after that and defunded in ways that made them almost impossible to navigate for many people. But I do think that they funded several institutions and created things that went on to have positive lives beyond their own too. And I'm not sure if you came to when Joanna Fernandez was here to talk about the Young Lords and things like that, but a lot of that funding really comes out of that war on poverty moment that those social, radicals essentially were able to harness to create community healthcare clinics and other sort of small pockets of intervention that I think are continue to have impact today and mitigate some of the worst effects of our health system. I think that if we understand both Medicare, Medicaid, and the New Deal, which is something historians love to debate, as good in the possibilities that they create but don't necessitate, that's sort of a helpful framework because they are kind of the grounds that people bring lawsuits and challenge things and have moments of expansion. So yeah, that's maybe an all over the place answer, but those are my 2 cents there.
I want to just offer one thought in closing, which is that, at various points, we've sort of zoomed out from healthcare to say there's the social determinants of health, that health is produced by all kinds of conditions, including your access to income, your working conditions, your housing, and so forth. And so, especially if we're thinking about health at that level, it becomes really important to not only think about how do you build out a healthcare system that is more universal, but also how do you build power for ordinary people to be able to insist on better wages, on better housing, on control over community environmental issues and all of that. And so I think we have to be able to think about health in a mobilizing context, right? Not just can we get this change made, not to say we shouldn't make those incremental changes, but do they help us build power? and mobilize people such that at the next stage, or for the other issue of, you know, I mean, you and I started talking earlier about labor power, right? We haven't talked about it in this panel, but conceiving of really broad shifts in the drivers of health inequity, or even in health insurance without thinking about expanding the power of labor, I think is unthinkable. Right, and so we have to also think at the same time, why could you come at the same time, about, you know, how do we get incrementally to better systems, and also how do we build power to sort of get there. So thanks so much for this panel.